Can you see the presentation okay? Yeah. You can. Okay, cool. Right. So, the ex-prem on NICU. We've all seen many of them, right? And so anybody who's done more than 10 years of PICU will know the nature of PICU has changed over the last 15, 20 years, maybe. And not just in terms of acute admissions, but also in terms of long-term respiratory support, tracheostomies, dealing with sequelae of being very premature. It's got a big impact on PICU work and the PICU life, whether you like it or not. And inevitably, what's happened is that is a consequence of the fact that neonatal survival has improved, right? So on the slide, just an example of the fact that basically at over 30 weeks, I mean, survival is, pretty much at 100%. And the thing is that when you look at the younger groups, that's the thing that's really changed a lot, right? So, I mean, you can see the most extreme one, the 23 weekers, gone from, 20 something percent to over 40%. And similarly for 25 weekers, there's 80% survival to discharge now, right? But, hopefully you guys will know that survival is a very crude way to look at neonatal success, right? I mean, survival means you're alive, but I mean, at what cost and what morbidities are associated with that? But there's no doubt that obviously neonatal care has got better over time, right? But the difficulty is that we know that those kind of babies are disproportionately make up a disproportionately greater amount of PICU admissions than the general population, right? So, the thing I picked out is that, 3.8% of babies born less than 36, and they make up about, 13% of the PICU cohort. And the smaller gestation you have, or the younger gestation, the more preterm you have, both the number, I mean, it's got a, I mean, at term, there's also, but I mean, if you look at purely the numbers, then it's obvious that actually, there are kids born at term who do come as well, for kind of avoid different kind of postnatal things. But if you look at it as, a percentage of babies born, then it's very obvious that babies who are born prematurely are much more likely to come to the ICU. But we see that. I mean, I'm stating the obvious. Yeah, sorry about that. So the thing is that, it's quite a hot topic in the intensive care world. That was a little while ago, to try to characterize the fact that the population of children we're looking after has changed, right? And one good reason to do that is to really understand the demographics of the patients you're dealing with, but also potentially being able to work together with, the neonatologists in the world and try to make, some service planning, but also kind of in terms of resource management and stuff about what we're going to do. And one of the things that, we looked at quite a lot is bronchiolitis and things, and I'll move on to that. But, you can't escape the fact that, of the children surviving to 1 year of age, I mean, at least half of them will have some morbidity, right? And then the younger the age, and how they, in other words, how old they are now, the degree of prematurity, and then you add kind of things like co-infections, comorbidities, RSV infection, so that the length of stay is much longer if you look at, and so the article that I was just getting these figures from, I mean, it just looked at acute bronchiolitis. So in patients who they looked after with acute bronchiolitis. Obviously, prematurity and all those other things, produce a longer length of stay. And also keeping in context of the fact that, for children born less than 29 weeks, there's, almost half of those who have some degree of, chronic lung disease, if you like, but some evidence of some lung pathology. So when you look at ICU admissions and you try to get a pattern of what neonatal success does on the PICU population, again, it becomes obvious that gestation and admission are closely linked, right? So if you look at, but there's two ways to look at that. There's planned admissions, in other words, ones which are dealing with, elective procedures related to being very premature, and then the unplanned ones, which are essentially the ones which are, acute medical emergencies, if you like. And you can see there's a big difference between, like, essentially being born not very premature, like 32 weeks. The percentage is, less than 5, it's 2 or 3, and in less than 24, it's very much large. So it's pretty well correlated, the relationship between prematurity, gestational age, and the chances of coming into PICU as an admission. If you, and again, gestational age and things like that, and it's not just gestational age which has a correlation between ICU admission and between, sorry, I'll rephrase that. Gestation is not the only thing that correlates with PICU admission. Also, the presence or absence of BPD or chronic lung disease, and the presence or absence of a brain injury also correlates with PICU admission. NEC for some reason doesn't particularly, but those are the kind of things that, if you're looking at the major groups of pathologies, you're looking at lung pathology, brain pathology, gut pathology. And really what I'm trying to say by this little thing is that, they're all interconnected essentially. So the thing is that if you have a respiratory morbidity, then you're much more likely to come in. And then when you come to ICU, to have kind of sequelae after that, that's a big group of patients who are essentially coming in with respiratory problems, but also developing other problems sort of later on as part of their PICU stay. I'm not sure why that thing is still there, but that's slightly covering my thing. Anyway, I'm going to go back to that previous view if I can. Okay. So basically, the chances of coming to PICU are greatly increased by small gestational age or early gestational age, BPD, brain injury, and the greatest percentage is respiratory disease. A high proportion of children who come to PICU come into PICU again. In other words, the recurrence, the readmission rate is higher in these patients, quite high. In other words, if you come in once, you're likely to come in again. Again, this is common sense. We see it all the time, right? And the impact also is not just on the child, but we see it again in the effect it has on parents who have to come to PICU again and again. And there's a combination of, the trauma of coming every time, but also on the other hand, that what we see is the desensitization to critical care, and that, if you spend many months on an oscillator, and then you spend a lot of time on CPAP, and then you go home and you come back with bronchiolitis, you're up on CPAP. A lot of parents say, well, they've been on it for a long time anyway. It doesn't have the same impact necessarily that it might do if you had a child born at term and you see very anxious parents or kids with bronchiolitis. Some of the neonatal parents seem very nonplussed by the whole thing. So if you try to think about classing the issues that they'll have when they come to us, right, is that the biggest thing is obviously you're born at term, you're born alive at whatever gestation. We've already talked about the fact that, you know, the chances of coming are greatly increased by being premature. But the three biggest things are respiratory disease, neurological problems from intracranial hemorrhages, sequelae of necrotizing enterocolitis, and then retinopathy prematurely. But that doesn't really affect, you know, their further life in that it won't, you know, cause them to come back into PICU. And then the morbidity that transfers onto at an age where they're going to come in is the cardiorespiratory ones, infections, and then kind of neurodevelopmental problems and things, and the kind of parental thing is tied into that. So, you know, imagine, as you often do, you get a call from Bedford Hospital, somewhere else, 3-month-old, ex-prem, respiratory symptoms, low-grade temperature, all the family have had colds, comes into A&E, desaturated, needs oxygen therapy, grades up to possible, you know, high flow, CPAP or something, and then you see this X-ray, right? And obviously, as you see that first X-ray, the first question is, well, how prem are we talking about? It turns out that this is an X27 weeker, had a prolonged stay on ventilation, had prolonged wean on CPAP, and went home on oxygen, had an echo done before, she has high pulmonary pressures, and sits normally on a you know, with a CO2 of 8 or 9 or something, by cover 40 odd. So when you get that call, right, I'm not going to ask you what you're going to do because it's obvious what to do, but what are your thoughts about what you have to do, what your preparation should be if you know that history? In other words, can you predict how their ICU stay is going to be and what may you need to do to try to address that? It's going to be a prolonged, yeah, it's probably fair to say. Yeah. So okay, yeah. So how's that going to affect what you do from here?
We'd have to talk to the parents from the very beginning.
Yeah, I think we probably do, right? But I'm gonna hold that thought for a minute. I'm just gonna ask you the medical things at the moment, right? So you know, probably the things you're thinking is that this child has already got premature. It's already got, from what I told you in the earlier slides, already got chronic lung disease. That's, you know, going to be highly predictive of one coming to PICU and having a prolonged PICU stay, right? So we know that that's, you know, well evidenced in the demographic stuff I showed you before. And they're probably going to deteriorate ventilation relatively quickly. Their reserve is going to be small. They're going to deal with stress a bit better because, you know, the lungs are being fibrotic. Their right heart is not going to be able to cope with hypoxia that well. They're probably going to end up intubated. And what would you think about the course on ventilation? You already said prolonged, but, you know, in the first couple of days, what can you imagine might happen?
High pressure on the ventilator, difficult to oxygenate, might make night.
Yeah, I think that's probably safe to say, right? So let's pull that apart a bit. So you think they're going to need high pressure, right? So why do you think they're going to need high pressure? Yeah, but I mean, you know, talking in ICU language, what does that mean? I mean, what's the
reduce compliance?
Yeah. So they have stiff, non-compliant lungs. Like they often need high opening pressures, high plateau pressures to try to get a good gas exchange. Yeah. What else? Yeah, so they might need nitric, right? Because they're going to have refractory. So the other problem is refractory hypoxia, and you're imagining that there's going to be an element of pulmonary vascular disease, in keeping with the lung fibrosis stuff. So you're going to have to do something about that, right? So you're probably going to need nitric. Yeah. Anything else? Sorry. Yeah. So you're going to need something that's going to tackle the pulmonary vasculature, right? Okay. Yeah. Yeah, don't interrupt, please do. Yeah.
Where do you see all blood test order?
David will delete that from the talk. Yeah. Yes. And yes. Where were we? Yes. So poor lung compliance, pulmonary vascular problems. Anything else that you might think that you probably have to do? Where they're kind of right heart that's not working so well, and yeah. So I mean, they might need diuretics, right? That's one thing. They might need. Well, let's talk about the management of pulmonary hypertension in a minute, but just in terms of the lung compliance and things. So they're going to need high pressure ventilation, a lot of oxygen. Any other modalities that you know that you might end up having to use? Yeah, you might have to prone them. Anything else that you? Yeah. Might have to use the oscillator. So just when you get the call, before you even do anything else, you're kind of thinking, oh, I might have to do all these things. And then obviously if the child's got pulmonary hypertension, then you're thinking, well, I might need to add some minotrope, I might need to start nitric, I might need to do kind of, probably not the first day, but kind of further things later on, but other pharmaceutical manipulation, sildenafil, prostacyclin, all those sort of the things. Do I need an echo? All those sort of things. Diuretics. So the thing that correlates after gestation the best thing with ICU admission is the presence or absence of BPD or chronic lung disease, or whatever the nomenclature is. So obviously that's sort of categorized by oxygen requirement on discharge, prolonged respiratory support if they need it, like low flow oxygen all the way up to CPAP, multiple hospitalizations before, chronic symptoms. So all the sort of things that you see in terms of cough, in terms of things like anatomical things like sunken sternum and exactly that. When they're a bit older, things like for babies, exercise tolerance basically means feeding, which means that breathless when feeding. Most of the kids will grow up by the time they're ambulant, and then chronic symptoms that kind of persist into childhood. Right? And so the things that you're going to see with it really are there's a vascular element to it, right? So this is what we're talking about, the need for nitric or not. So they're going to be the pulmonary vascular can either be more reactive or less reactive, depending on how much fibrosis and stuff you have. The tone is always up. And then the implication is it causes more hemodynamic instability. There's also disrupted vascular growth. And so that's another reason that you get, high pulmonary pressures. And essentially you get all those kind of things together that kind of give you a bit of pulmonary hypertension as well. So that, that they go kind of hand in hand, right? Also in terms of when you're talking about pulmonary hypertension is that it's important to know the cardiac connections, to know that, is it a normal heart? Is there any other thing that's contributing to the pulmonary hypertension? Do you have any particularly if you have an interatrial shunt, that can help you sometimes, what other connections there are as well. It's important to look at the pressures on the right side. So often we have elevated pressure on the right side, how the RV is functioning, and if it's functioning very badly, it might have implications on, global heart function. So when you so the predominant thing really is going to be respiratory. That's probably the thing that you're going to have to deal with the most, right? On top of that, I couldn't find a good slide for pulmonary hypertension, but when you're dealing with pulmonary hypertension, the basic things, there's a whole talk about pulmonary hypertension, but the essential things, intubation, ventilation, make sure you have a good oxygenation, You're going to control the pH because pH is a good has an effect on pulmonary vascular constriction. So you have acidotic, you get more constriction. So you try to keep children on the alkalotic side. You're going to make sure that you have good perfusion. So you may need to increase your blood pressure to promote left to right shunting, rather than the other way around. You're going to try to keep the PA2 above a certain level. Obviously, oxygen is a potent vasodilator. You're going to make sure they're sedated and paralyzed with adequate sedation, and you're going to try not to stimulate them too much, don't poke them. I mean, those of you that seen pulmonary hypertension knows that if you poke a child and they've got pulmonary hypertension, everything goes south. So those are all the kind of things but you should be thinking about all these things on the phone before they come, because you're going to have to probably use them. So often what you'll find is that if we have a story of going back to the X-ray, a kid like this, you have the oscillator sometimes will prepared, will have nitric prepared, inotropes prepared, and prepared that you're going to be and I mean the other thing obviously is that with a small baby is that you have to have an adequate tube size to be able to ventilate somebody in the way that you might want to do it. So if they come with a small tube and that the next prem they're going to need high pressure, then you really should be thinking, well, is the child well enough to give me scope to get an appropriately sized tube in, because there's no point trying to ventilate someone with high pressure with a very small tube, because the pressure won't get to the lungs, it'll just dissipate around the leak. So if you get a call about a next 25-weeker who's high pressure ventilation, they've got a 2.5 tube in, and that's one of the things that you're going to struggle with. Right? The second thing is really kind of what I would call neurological. In other words, the effects of the presence or absence of neonatal encephalopathy for whatever cause, plus or minus intraventricular hemorrhage. Right? So we all know that there's a whole variety of neurological conditions that the neonates can suffer, and if you bundle them into kind of generalized neonatal encephalopathy, that primarily, and that is HIE, which essentially is a hypoxic ischemic insult to the neonatal brain, which will produce can produce very profound neurological symptoms. So that might present as developmental delay, seizures, cerebral palsy type picture, but in a small age group may just be hypertonicity, neonatal stroke, which can be a vascular phenomenon, which can be something that's like a congenital malformation, can be acquired, it's pretty rare and acquired, but those sort of things, but also can be due to AV malformations and things. Then you're thinking about the sequelae of infection and meningitis. So that could be hypoxic ischemic from shock and stuff, but also could be kind of, primary, could be strep in the brain that can cause, essentially parenchymal damage from that point of view. And then there kind of sort of congenital things that you might just be born with. But in the context of HIE, essentially you have a hypoxic injury, you have primary energy failure in the neurons, you get a secondary inflammation and fibrosis and dysfunction, then you end up with some kind of brain damage, and you end up with dysfunction. And the sequelae of that will bring you into ICU. Right? So the things that you be concentrating on the most is, well, what do you think the number one thing is that will bring you into ICU after HIE? Aspiration, and there's one, I mean, aspiration and something else, but yeah, so poor bulbar function, poor management of secretions and whatnot, and aspiration, that's one, and the other one, seizures, so seizures are the two big ones that will bring neonates back in. And the management of seizures, as you know, kind of in the neonatal group, tends to be sort of very phenobarb related, albeit associated, should I say. But obviously the degree of neuro disability is dependent on the primary injury, obviously kind of complications of the neonatal stay as well. But you know, there's going to be a fair proportion of kids that will come with a brain injury. But if you actually think about, you know, there are children with seizures. I mean, neonatal seizures are very common, right? I mean, you know, lots of kids have funny movements. But I mean, from our point of view, they don't always come with a diagnosis. And so we have to try to, outside the realms of HIE, there are a whole variety of neonatal conditions, so which I put on, I mean, some of them are structural, like we have a whole variety of kids, you know, listen carefully, you know, and, you know, we'll have MRIs will be either, you know, essentially what are embryonic migration defects. In other words, the brain does not develop adequately, and the right things don't migrate to the edges. And so in things like listen carefully, polar microgyria, all those sort of things will, you know, in the neonatal group. So, and sometimes they're not diagnosed, right? So, you know, classically, as you know, a neonate 2 weeks old comes with seizures, you know, that's the sort of thing that you, and in the absence of meningoencephalitis, you know, some of the time these will be, you know, structural defects. You know, there's a small amount of children that may come, you know, with things like, you know, fetal alcohol syndrome, fetal drug dependence, even kind of drug withdrawal sometimes, but they're kind of pretty small. And then there's all the genetic stuff, which is, again, another whole talk in itself. But the primary thing for us that we're looking at is the HIE babies, seizures for a whole variety of reasons. And as you said, kind of bulbar function, aspiration, all those kind of things. The other things that we'll be dealing with is the post-NEC surgical baby, right? So classically, the child's had a period of gut, either hypoperfusion or enterocolitis. That's resolved, that's healed. You get adhesions, and there are kind of two groups of those. So the kids who would prevent in subacute or acute obstruction, and then there's the other set of kids who will have a bowel resection, and either will present with something to do with that, or may well present with a whole variety of other things, which are, one can be sort of malabsorption, electrolyte disturbances. They can be kids who are on TPN and have a line, and then they get infected, and you know, occasionally there will be kind of complications if, for example, they had their bowel removed, then, you know, stomach care, you know, infections and all that sort of stuff. And sometimes it can be a long time afterwards. And that's outside the realm of, you know, neonates in general that, you know, can have malrotation, volvulus, interception, but particularly in the neonatal, the ex-prem, ex-NICU graduate, it will tend to be either, you know, previous episodes of neck and then lesions or something related to that, or it will be the kid who's had bowel removed and has to deal with all the complications of bowel removed. TPN dependency is another one, you see, because the thing is that it's not so much to do with the TPN itself, it's to do with the line. So the lines get infected. And occasionally there's electrolyte disorders, but normally it's line problems. And short gut is the same. Developmental delay, I've just put on there because it's really related to all the neurological things, so I'm not going to go with that stuff again. ROP is a very common sequelae, or well, as a consequence of being on the NICU, but you know, I don't think it's. I mean, occasionally, a child who needs an elective procedure on their ROP will come because they're still in oxygen or they still have. So it's not the eye itself; it's just, you know, because in that first chart I showed you that elective admissions for these kids go up too, right? I mean, it's just, I think so. And occasionally, you know, I was trawling through the list and the reason that you'll come in, and sometimes, you know, if you have a kid who's either very fragile, they will come in for their vaccinations, or what may happen is they have a previous vaccination reaction. Because some of the time what will happen is because, like, for example, RSV vaccination is multi-stage, and they might have a couple of them on the NICU reacted badly before. And so for the third one, although they've gone home, they might need to come back to HDU, for example, for the third one or fourth one or whatever. So that's pretty much it. And then the last 5 minutes, I was going to talk about LTV. So this is a big issue, obviously, for us. So the thing is that you've already seen, and I won't repeat this, but the presence or not of bronchopulmonary dysplasia does massively increase the chance of you coming back to the PICU, right? But not just that, is that it also does massively increase the chance of you needing either some respiratory support, invasive or non-invasive, at term, right? So the thing is that, oh, what's that? That's not good. Has it come? Oh, sorry, yes, it's a bit delayed. Okay. So, as I said, is that the need for chronic respiratory support has produced a whole variety of kids now that need intensive care input after birth to manage whether they need positive pressure, whether they need tracheostomy, and whether they need any ongoing things. And those things are also associated with gastrostomy needs, with long-term line needs. So they all kind of go together. So for us, and when I say us, I don't mean PICU, I mean, pediatrics in general, is that there's the massive new group of patients of ex-prems, NICU graduates that need this care, right? And so the issue that we have at the moment is the resourcing for how to look after each other, because there isn't any. The bottom line is there's not adequate provision really in terms of inpatient stay and community services to deal with this population, right? So one, we know that pretermers need a lot more than need chronic ventilator care, right? If you add all the comorbidities that come along with that, then that also gives you another thing that requires resources. In addition to that, there's a whole variety of airway children who are born prematurely that need airway support. A classical example we have at the moment, who don't have chronic lung disease as such, but have airway issues, which need positive pressure or need some kind of airway. So they are also adding to that patient group. And there are massive variations, both nationally and around the world, into how we deal with these children. The first world has become very trachea dependent. And so the numbers of tracheostomies are going up, the number of children needing long-term positive pressure is going up, and the options that those babies have, it's going up. So that has a knock-on effect on PICU care. And the optimum strategy for these things is not really known. I mean, some centers you go and will tracheotomize lots of patients, some of them don't do at all. I think we kind of sit in the middle, probably towards the lower end, I would say. But there isn't any national guidance about exactly what to do. I think there's a bit of benchmarking that goes on. I mean, the respiratory team, like, someone like Theo or something else, a bit better more than I do, but there's some, I think there's some benchmarking, but not a lot. But there's certainly not necessarily consistency about if a kid has this, then tracheostomy, and it's not quite so. But as you can see with our 3 kids on HDU, it's a massive MDT task to try to get them out of hospital. It involves, in-hospital care, ENT, respiratory, social care, community care, physiotherapy, occupational therapy, speech and language. It's a huge thing, and it's not well resourced, and it's not well funded. So, it's a real big conundrum, in that if in 10 years time, I'll relate you back to the first slide, right, is that line is just going up and up, survival, okay, and the resources are going down and down. So that's the state of play we're on at the moment. But yeah, that's as well as the acute neonates with respiratory failure needing high pressure ventilation, etc. Almost the biggest problem that we have is actually chronic respiratory support. Good. Well, that's all my slides. I'm going to come out of this. Hang on. Sorry.